patients now are very different than patients from 30 years ago. They expect way more of the staff. They are more demanding, they're more critical. And so people who work with these patients feel enormous pressure to meet the needs of the patients. And that falls on the physicians and the nurses and the whole team. And so people are really stressed.
How are clinicians doing? Patients are expecting more from their clinical teams than ever. They are quicker to leave scathing reviews, and they offer fewer tokens of gratitude than they did in the past, according to my guest. Does that sound familiar? Dr. Alice Domar is back on the program to share what can be done, like burnout prevention, like one tiny little intervention that increases patient retention. 3 psychosocial trials that she's running right now at the Inception Research Institute, and how Inception and the Research Institute give her so much free reign to be able to conduct research that helps improve patients converting to treatment and their engagement and their satisfaction, and the same for clinicians. She talks about characteristics of patients who are more likely to drop out of treatment, cool things that Inception does to support their providers and patients, like empathic communication training for clinicians, and giving every patient who wants one a copy of Dr. Domar's recently updated book, Conquering Infertility. During this interview, I zigzag between the challenges providers have and the challenges patients have, and I think Dr. Domar shows how these issues are interwoven. She also talks about why embryologists face an even greater level of stress and anxiety, and the average tenure of a fertility nurse has been cut in half from 4 years to 2 years. Allie got me fired up about fertility nurses. I promise we'll tackle more issues in 2026 that are issues for fertility nurses. There are times when nurses are completely ignored, and I'm fed up with it. Enjoy this conversation with Allie Domar as she sets the stage for why. If you like the information in this episode, we're compiling so much more data on new technology in IVF, products, services, market analyses, info on mergers and acquisitions, and data on every company in the fertility space. Go to data.insidereproductivehealth.com. If your company isn't an IVF Heroes Universe sponsor, your competitors are so much more visible to your customers because we report on your category and we give that info to your customers. Go to data.insidereproductivehealth.com to learn more about other fertility companies or submit your company today. Don't be left out.
Today's advertiser helped make the production and delivery of this episode possible for free to you. But the themes expressed by the guests do not necessarily reflect the views of Inside Reproductive Health nor of the advertiser. The advertiser does not have editorial control over the content of this episode, and the guest's appearance is not an endorsement of the advertiser.
I'm the Chief Compassion Officer at Inception, and so I feel like I'm responsible not just for patients, but for our employees. And it's hard. I think I know patients now are very different than patients from 30 years ago. They seem to be, they expect way more of the staff. They are more demanding, they're more critical, they post negative reviews on social media. And so people who work with these patients feel enormous pressure to meet the needs of the patients at the time where, everyone's worried about volume and everyone's worried about, meeting the numbers, and that falls on the physicians and the nurses and the whole team. And so people are really stressed.
On any given night, who are you more concerned about, patients or clinicians?
Yes. Well, I'm a psychologist. And so, I always feel for patients because infertility is such a traumatic journey. But I'm shocked, at least on a weekly basis, at how patients treat people, nurses and doctors and front desk staff and phlebotomists and ultrasound techs. I mean, the lack of respect, the raised voices, the swearing, and again, probably 90% of patients are wonderful, but it's the 10% that make people think about leaving.
And so it seems like there's been more of this in the last 30 years. They expect more of clinicians. Is there anything that can be done about that? Is any of your research come across things that can proactively address those? Will we end up talking a little bit about that today? And if not, is there anything that can be done about that?
Well, there is such a thing as burnout prevention. And, Liz Grill, who's my work wife, she and I once a year do on a cruise ship, a burnout prevention course for healthcare professionals. So the one we're doing in 2026 is a cruise from Athens to 2 islands and then 48 hours in Cairo. And so we actually have an opportunity with mostly physicians, some nurses, et cetera, to actually do hands-on experiential burnout prevention strategies. But that's what I do with all the Prelude Clinic staff. I do a lot of what we call stress lunches where, I try very hard to give them a sense of what patients are going through and talk about how hard infertility is. And a lot of people don't really think about what patients are going through in terms of, the patient may be nasty to you today. And it's because last night her little sister called and said she was pregnant by accident, which, for an infertility patient is very traumatizing. And so I think it's really important for everyone who works in the field to understand psychologically what our patients are experiencing and all their triggers. But yeah, we teach, relaxation techniques and stress management techniques and communication strategies and, how to use these apps for example, we got the app company Calm to give us a deal so that every Inception employee not only has access to Calm, but 5 of their family members do too. And so I encourage everyone to do some form of relaxation every day or to use them when a patient pushes your button, which happens to a lot of people all the time. But it was interesting. I was in Australia a month ago for the Australia-New Zealand annual meeting. And there was a lecture, but I got to a little late because I'm on crutches after knee surgery. And it's by a psychologist in Australia named Elizabeth Bancroft, who herself is autistic. And she specializes in working with infertility patients who are on the spectrum and or have ADHD. And she presented all this data on the fact that for women on the spectrum, the prevalence of endometriosis and or PCOS is much higher in that population. And patients who are on the spectrum handle infertility treatment very differently. And they really need, in effect, special care. And their dropout rates are high. And I'm listening to this lecture and I was gobsmacked because in my 37 years in the field, I never really thought about how do women on the spectrum handle this. And I wonder if those are the patients that we see as red flags because they don't interpret things the same as women who are not on the spectrum. And so things like fluorescent lighting or noise in the waiting room may really bother them. And the average nurse or physician may not understand that.
What's the relation between the population on the spectrum and the population with ADHD? I would generally think those are two very different populations, but do they have commonalities?
They do have some commonalities. And in fact, so since I got back from Australia, I've been communicating with Dr. Bancroft and another colleague of hers because what I want to do is she has a 40-item questionnaire to basically identify triggers for women on the spectrum and or women with ADHD to see if they need, and she's developed a program to meet the needs of these patients. And she has a 0% dropout rate from treatment in women who go through her program. And what I want to do, and I'm trying to do now, is take her 40-item questionnaire, which is way too long, and collapse it into maybe a 6-item entity that we can give to new patients to know if they have certain sensitivities that the team needs to know about. Maybe a little extra TLC, maybe dim the lights, things like that, which will meet the needs of those patients and allow them to withstand the rigors of treatment. And so they can stay in treatment until they have a baby. That's one of my big goals right now.
That really would be something that you might be able to prevent some of the backlash that comes from patients who are having a really hard time. If you could get ahead of knowing that there are some particular preferences that maybe are beyond just preferences, that if they're accounted for, you get less of that backlash later on.
It's sort of prophylactic. If we know a patient has sensitivities from their patient questionnaire, we can hopefully at least know about them ahead of time. And so they don't get triggered and they stay in treatment. I mean, the other big thing I've been working on is to try to, I've been doing this for 12 years, to try to figure out which patients are at highest risk of dropping out and what can we do to support them better and keep them in treatment until they get pregnant.
Tell us about recent studies that you've done, or as recent as you're able to talk about, and what characteristics are patients most likely to have that are likely to drop out.
So I was invited about a year ago by the journal Human Reproduction to write a lit review on psychological interventions to reduce dropout rates. And I thought that'd be, I was very happy to be invited, and I did it with one of my interns who was a college student. And this poor kid spent hours and hours and hours and hours and hours researching, trying to find any published research other than mine on how to prevent or what psychological interventions. And there are literally 2 published studies, and those are mine. So either people are not adequately paying attention, or people, I don't know why. So the first study we did was we did it with Jackie Boyvin, and it was supported by what's now called Organon. And we recruited, I think it was 240 women, anyway, who were about to do their first IVF cycle. Half of them randomly were mailed a stress management packet and had relaxation strategies and cognitive strategies, et cetera, et cetera. And the other half randomly were not mailed that packet. We had no contact with them whatsoever for a year. And then at the end of the year, we looked at the dropout rates. So we didn't know if the women received the packet. We didn't know if they opened the packet. We didn't know if they used the packet. But their dropout rates were 67% less than the control group. And they were less anxious, and their quality of life was better, and they coped much better with treatment. So we published that study, and nobody asked us for a copy of that stress management packet. And here, you would think that any clinic in the world would say, wow, this packet costs $12. And nowadays you could probably make it all available electronically. So it would probably not cost anything. And you can reduce dropout rates by 67%. You'd think that's a gold mine. And then we published another study, I don't know, maybe a year or 2 ago, where we looked at patients who had had their new patient consult and never came back. And we, 3 months later, sent them an email saying, hey, we just want to know why you didn't come back. And is there anything we could have done to support you to come back? Sending that email statistically increased their chances of coming back. It doesn't cost anything to send an email. You can do it automatically. So what those 2 studies showed, there's almost these tiny interventions dramatically increase retention.
How much more likely were they to come back if they received that email?
I think it was 42% versus 31%. I think there was an 11% difference. I don't have you think I should have my own stats on my own head, but I'm too old to have my own stats on my own head.
But it's pretty significant.
It's hugely significant.
That means you're converting a quarter more of your patients in that case. And we saw something similar when we were helping clinics with marketing. We would help them a little bit with conversion, and that was one of the things that we found is that if you set up an email sequence and reach out to those patients, you will convert more of them just by touching base with them. And it can be a really low cost intervention.
Well, every clinic in this country, or every clinic everywhere, is hemorrhaging patients because, it takes a lot of time and effort to get the patient in the door, and then they drop out. And, again, from a psychological point of view, someone who has infertility, has been trying for a year or 2, is probably unlikely to spontaneously conceive at that point, which means if they drop out, they're unlikely to become a biological parent. And if they're dropping out because of stress, which is, obviously money is the number 1 reason people drop out. But the number 2 reason globally for insured patients is stress, which means we're not doing a good enough job. If patients are dropping out because they're simply too stressed to continue, we're not doing our job.
Last I spoke with you, clinics weren't doing the best job of measuring their dropout. Has that gotten any better as networks are really focused on their patient pipelines? Are they measuring more now?
Yeah, well, because EMR makes it much easier. So it's much easier. You can push a button and know what your dropout rates are. If you have someone who's able to do that kind of data analysis, it's huge. Dropout rates are huge, and it's global. It's not just in the US.
Did you vary the email at all? Like experiment with this copy versus that copy?
mean, the funny thing was it started out as just I wanted to know why. Is it because you got pregnant? Is it because you didn't like the center? Is it you didn't like the doctor? Is it, you know, and then we added a paragraph at the end saying, if there's anything we can do to better support you, please. And we gave a person's name and a phone number. And so we did that for, I think, 5 months. My research assistant at the time sent the email, and then she had the audacity to get pregnant and went on maternity leave. So for 3 months, we didn't send the email. And when she came back, I said, I wonder what our dropout rate was when we sent the email versus when we didn't send the email. And that's how we got that data. So it ended up being a publishable, quote unquote, study, but it didn't start that way. It started as me trying to figure out why patients were dropping out.
In either of those studies or any others, did you find characteristics of patients that were more likely to drop out? Like college-educated women are more or less likely, or from this type of background. Can you tell us the characteristics of the profile of patients who are more likely to discontinue treatment?
So we didn't look at it in that study, and I have not done the research, but there's been a ton of research out of Europe where I think there are 10 different characteristics that in effect predict dropout rates. And the ones I'm most interested in are being depressed, which more than half our patients are, having inadequate partner support. Ironically, one study out of France showed the more frozen embryos, the more likely they were to drop out, which is counterintuitive because the more frozen embryos one has, the more likely one is to get pregnant. There are a lot of different, the older, if a patient in her 40s is more likely to drop out than somebody in their late 20s or early 30s. We actually did a study on that. So there is a relationship between age and there's a relationship between prognosis. Then if you have patients who have, extremely low AMHs and their physician has said, give up, yeah, they're likely to drop out. But the ones that we can change depression levels. Hopefully we can change partner support. We can't change education level, et cetera, but we can change the psychological one.
That's interesting to me about partner support. There was an article in Inside Reproductive Health recently, a company called Q Engage that they help with a number of different things, and one of them has to do with online reputation management. And they looked at negative reviews, and a lot of it had to do with how the partner was engaged or not engaged. And to hear inadequate partner support being a factor in dropout, well, there's some of that you can't control, right?
No, the partner's a jerk.
But there
you
might
can't
be
change.
You can't change if the partner's a jerk, but you might be able to extrapolate some of that to say that, an engaged partner may be able to help more than a non-engaged partner.
Absolutely. As I said, the frustrating part is there are some things you can change that people are not changing. And actually, when I was doing that research, excuse me, I interviewed about 250 patients who were fully insured. This was in Massachusetts, where people have 6 IVF cycles covered. And these were patients who had insurance and dropped out before getting pregnant, before using their insurance. And so we actually interviewed them, and every single one said it was a communication issue with either their physician or their nurse or their team, and they just couldn't handle the stress. And that led to me starting to do empathy training. And so I've been bopping around the country training our physicians in empathic communication. And so, in fact, Fairing has been sponsoring these dinners where I go to any of the Prelude clinics and we have a nice dinner. And then it's actually fun because I explain all the science about empathic communication and I, go through how to actually communicate empathically. And then I have 14 vignettes on the hardest conversations an REI ever has. There's no heartbeat on your ultrasound, or, your AMH is too low, or an employee is not doing a good job, or a nurse has made a mistake. And so they role play. So the physicians either play themselves or the patient or the nurse. And the ones who are playing the physician, communicates this to the quote unquote patient. And then I criticize them. And I literally stand behind them and they do their thing. And I'm like, okay, that was good, but maybe you could try it this way. And it's had a really good impact. I've gotten some really nice emails from our docs saying, wow, you're right. This really does work.
And they do it right there at dinner?
Yeah, they role play at dinner.
Do you find them doing things in the role play that you see patients comment about?
Oh, yeah. I mean, they'll, again, these are really tough conversations. Like, how do you tell a patient she's got to lose weight? Or how do you tell a couple that there's severe male factor infertility? These are the 14 toughest conversations. And there are a lot of physicians who do a really good job. In fact, so what we ended up doing just to really get the message across is I went to two of our physicians who are just really good communicators, and we have the 6 hardest conversations. And so I had these 2 physicians with like fake patients or fake nurses. So we videotaped this and we had them do it badly as a not to do, and then we had them do it well as a this so and that's to train our younger physicians and how to have these conversations. And that's really helpful because, med school and residency and fellowship, there's not any really specific training on empathic communication. And a few years ago, one of our fellows actually did his fellowship research project on this, a randomized controlled trial, and found that empathic communication had a really big impact on how well patients cope.
Would you recommend or recommend against setting the stage? What I mean by that is when I'm having a direct conversation with someone, or if I have to broach a more difficult subject, if I set the stage that I'm going to have a direct conversation about a difficult subject with you, they're less offended, they're more at ease. And so if I'm a doctor, I might be saying, I'm going to talk to you about BMI and how that impacts your prognosis and treatment plans that I recommend. Some people might think that I'm calling them skinny or fat. I would never call anyone skinny or fat. And I am only going to talk about how BMI may impact your prognosis and what I recommend. Is that okay? And so I might ask something like that to disarm them at first. Would you recommend doing something
Yeah,
like
you'd
that?
be a
Or do you
great
think,
REI. You'd be a great REI starting the conversation like that. I mean, the focus really needs to be on health rather than on weight. But yeah, it's good to sort of what we call an emotional segue to sort of ease into the conversation. Um, and just say, I wish I had, if someone doesn't have a heartbeat or their IVF cycle was negative, it's like, I really wish I had better news to share with you, and to give them that segue into the conversation. These are these are the conversations our physicians and nurses dread because there's a lot of bad news being delivered in our field, and it's really hard. I mean, the problem with our field is our successes disappear. Once they have a good prenatal ultrasound, we don't see them again. We only see the ones who didn't succeed, who come back again and again and again, and that psychologically can feel catastrophic. So all you see are failures. You don't see the successes.
so you have a TikTok account, right? The Ask Allie, where patients can ask you different questions. Do you get these kinds of questions from patients that doctors would be on the other side of, or is it more of their mental health journey?
So I have avoided social media my entire life, and it was suggested to me that I stop avoiding social media. So we just started on TikTok and Instagram, or as my kids call it, the gram, me recording stuff, but also launching this Ask Allie, really about the emotional aspects of infertility, partner issues, family issues, lifestyle issues, alternative medicine issues, et cetera, et cetera. And so we literally just launched it a couple of days ago. So I haven't gotten questions yet, but I'm happy to answer them. It's easy. It's Ask Allie at inceptionllc.com.
Are you going to try and collect them in any way, like putting them into a spreadsheet or anything so that you could analyze them after a long period of time? Put
Hadn't
them into
thought of
some
that.
kind of sample?
I suspect the marketing department will want to do something with them.
Yeah, I think that would be really interesting to see, putting it into a word cloud and seeing
Yeah.
um, what comes up the most.
I
So they
do
talk to you.
I do patient webinars once a month, and people for like the last 20 minutes can ask questions. And usually there are too many questions to fit in the hour, so then I just email all the patients back. I mean, it's the questions I've been facing my whole career. How do I cope? How do I cope better? How do my partner and I cope? When do I know it's time to stop treatment or move on to donor egg or sperm?
Do you find that they're asking doctors these questions? Are doctors telling you they're getting these sorts of questions and they don't know how to answer them?
They do get these questions, and, the ones who have been in the field for a while know how to answer them. I think for the new physicians, it's tougher because most of fellowship training is on the treatment of infertility, not the care of patients.
So, with the Research Institute, tell us more about what and how you do research at the Research Institute.
So when I got to Inception, 3.5 years ago, they had this little tiny research section, and I actually brought a study with me. And it was sort of decided that we were going to really try to grow the Inception Research Institute. And I got a couple psychosocial grants, but became very apparent to me really early on that what we really wanted to do was attract pharma trials and device trials. And I'm a psychologist, and I can't be the PI. And so several years ago, I started to court my BFF, Dr. Garang Daftari, and tried to convince him that he would be happy if he joined the Inception Research Institute. And he did. So October 1st of last year, he came on as the chief scientific officer. And so he and I sort of co-run the Inception Research Institute. I am in charge of all the psychosocial trials, and he's in charge of all the pharma and device trials. And knock on wood, it's been incredible. We are at capacity now. We're doing these amazing studies. And we're very attractive because we have one EMR across all of our clinics.
Why is that important?
Because you can effortlessly do a study and collect data across all our clinics. And so we have a grant now to do retrospective analysis, and you literally push a button and you get the data from 50,000 patients.
So with those two studies that you mentioned previously, were they through the Research Institute?
Yeah, all the research. The ones I said about the dropout, that was before I got to Inception. So we basically have 3 psychosocial trials going on. One is with Frame, which is the coaching support aspect. And we're doing a randomized control trial right now where patients are contacted after their new patient consult. And those who sign up to be in the study half are randomized to get Frame for free. And the others are controls for 3 months, and then the controls get Frame. So we're in the midst of recruiting for that. We're also doing a FDA registry trial with Curio. So we're recruiting patients who have been told they need to do IVF, and they're randomized either to use the FertiLift, which is a new online web-based cognitive behavioral platform, and half are randomized not. And then we've been doing, since I got there, trials with Auto, which is a company in Canada, which has a device that measures 54 aspects of physiological stress. And that's, all the research is exciting, but the Auto stuff is cutting edge.
So all 3 of these psychosocial trials are going on now?
We just finished collecting data on Auto. The Frame and Curio are ongoing now. Auto, we presented at ASRM last year, and we're in the middle, knee deep in the data analysis, and we're using the biostatistics department at Queen's University in Toronto because we wanted to use an impartial stats group. The results are going to be controversial. So, because what we are studying is whether or not stress manifested physiologically, either through the cardiovascular system or the central nervous system, is associated with IVF failure.
What can you talk about from what you published or discussed at last year's ASRM?
So the first study we looked at was when I say stress levels, I'm talking about physiological stress of patients during their baseline, which was 7 days before they started their IVF cycle, and then the stim cycle. So when they took medications. And I remember I was at ESHRE 2 years ago with the CEO of Auto, and he had just gotten some of the preliminary results. And he said, and this is the Auto has data from 30 years ago. They work with Navy SEALs and the NFL, and they used to work with like the Russian Olympic teams. They had never seen stress levels like they saw in these women during the stim phase of their cycle. And so what we presented at ASRM last year was comparing patients during their baseline versus their stim phase. And it was p-values that I, as a researcher, can only dream about. It was like p is less than 0.0007. So women were extremely physiologically stressed during the stim phase.
When do you expect that you'll be able to publish the remaining results of the second phase?
As soon as we can get the manuscript written. We're going to have, we have 3 different manuscripts. So I can talk about the baseline versus STEM because we presented it. And then we have another manuscript about how we are using, not me, the Queen's biostatistics guys whose IQs are 3 times mine, how they're using AI to create models about whether or not physiological stress can predict IVF outcomes. So that's going to be another paper. And the third one is the actual data. Can physiological stress predict IVF?
So are we talking like this time next year?
Oh,
or
yeah. I
longer,
mean,
a
it
couple
better
months,
darn
or
well be published within the next 6 months.
how
I do have
about
to retire at
the
some point in my life.
yes, well, are you gonna?
Not for a while. I need to
Good.
finish all this research, and I have a lot more to accomplish, and now I have all this autism spectrum stuff, so no, I'm not gonna retire anytime soon. Too much to
Yeah, we're
do.
giving you more rabbit holes to go down. There's
Yeah,
too too many stones left unturned, Allie. We got to keep you around for a while. I'll be interested in hearing about the results from the Frame trial as well. When do you expect to be able to publish that?
probably a year is my guess. I mean, you have to recruit patients, and then they all have to go through the 3 months, and then to collect
Yeah.
data and finish the data analysis, and then write a manuscript, which has, like, 8 co-authors on it, and you write, and you rewrite, and you rewrite, and then you submit it to a journal, and the first journal rejects it, and so you have to go to a second journal, and then the reviewers will have lots of it's a long process.
Was the Research Institute part of your initial charge when you came to Inception? Was that part of the deal, or what you came on as chief compassion officer, and then did you nudge TJ and say, "Hey, I want to do this kind of stuff," or did they come to you?
I mean, I came on as chief compassion officer, and TJ and I had 6 goals for me, and I brought that auto study with me. So I knew I'd be doing a little bit of research, and they had a research coordinator, Amber Mendoza, who's amazing. And I think when I got there, as a researcher, having one EMR across all these clinics is a researcher's dream. And so I realized that I could accomplish way more at Inception than I'd ever been able to do in my career. And so early on, Chris Bright, who's the president of Inception, said, "Okay, you're the director of the Inception Research Institute." And TJ, I mean, knock on wood, TJ has never said no to me. So everything I go to him with, he's like, "Don't ask me, just do it." So
There's going to be a lot more studies about patients with ADHD,
yeah,
DJ. There's a lot of different angles that you can pursue. Do you remember the 6 goals? Can you
no.
rattle them off?
But I do want to say is that the Inception Research Institute, within about 2 years of launching it, had more trials registered at clinicaltrials.gov than any other network in North America, which is great because it means we're turning. The 6 goals, gosh, no, I don't remember. I'm sure it's in my contract. I mean, obviously one was to create as many stress management programs for patients as I could. Number 2 was to create stress management programs for the staff. I wanted to put a mental health professional embedded in every practice, and that's on hold right now. Maybe research. I'd have to go back and look at my contract. That was 4 years ago.
Is it as important to have a mental health professional embedded in every practice as it was 10 years ago? Is there a lot that can be done with virtual therapy in your view, or does it really need to be in person?
It's a tough question because I don't think anyone's ever done a study on this, so I can't answer it. I would say that, I was at Boston IVF for 20 years, and I felt like, and there was a whole team of mental health professionals that were embedded. And we didn't just offer a lot to patients by physically being there. So, for example, when you're physically embedded, if a patient comes in for a prenatal ultrasound and there's no heartbeat, every patient in that situation was guaranteed to see a psychologist within an hour. And that's an amazing thing to offer to patients. And it meant that every staff member could come and talk to us. And so I'd say when I was there, it was half patient support and half employee support. I do think right now, I mean, since COVID, I have not physically seen a patient in 5.5 years. Everything I do with patients is on Zoom. And we know that therapy via Zoom is just as good. And so, yeah, you know, and Curio are both not live interventions, but there's something about a nice, warm mental health professional, physically being there to remind people that they're there. It's important.
No one's ever done a study on it with all of these therapy apps that are out there now. You would think that someone would have done a study to see if they're as good as in person, but I guess that would be hard to control for, right?
It'd be
Because
very hard.
you
I mean,
have different therapists.
yeah. I mean, there've been lots of studies comparing, online interventions to in-person interventions, but not specifically that I know of with infertility patients.
Okay.
I mean, to be honest, there's very little research going on in the US. There's almost no money available to do randomized controlled trials in the US. I mean, the federal government, I haven't heard of any funded research. So in the US, there's really not much going on. So one either has to rely on companies like Frame and Curio and the pharma companies. It's tough to get funding. So,
But
in Europe,
elsewhere in therapy, there have been studies, and
yes.
what do those studies show?
The study shows that remote therapy is as good as in-person therapy. So that's why you see all these remote platforms springing up.
You've updated your book, Conquering Infertility, recently.
That's so kind of you.
What's new?
What's new? So, what's really interesting is that Inception wanted me to update it because they are now giving away free copies of Conquering Infertility to all their patients. And so the publisher sent me the Word document, which was written probably 25 years ago. And my assignment was to update it. And clearly there was a fair amount of medical stuff. I mean, in the original version, there's all this talk about having a high FSH, which obviously converts into low FSH. And there had to be updates about PGT and all the other medical stuff. And I added a lot more content on LGBTQ, and I changed all the pronouns. And when we read the book originally, it was really meant for heterosexual couples, and we had to make it much more broad. But the emotional stuff hasn't changed. I mean, I had to change names because names that were popular 25 years ago are not popular now. And so I had to look up popular names from like 30 to 35 years ago. But no, the emotional stuff. I mean, I have a small private practice, so I'm still in tune with patients, and the emotional stuff I didn't have to revise.
So Ashley used to be the baby's name, and now it's the patient's name. Linda's out of the picture, and
yes, Karen's out of the picture.
Now the baby is Olivia.
Yes, Olivia, Ava, Maya. The names have changed. Like boys have to be, Noah and stuff. So yeah, I did change all the names. I also had some fun. I don't know if anyone in Inception has caught this, but I changed a lot of the names to people I work with. So there's Lindsay and Kat and Amber.
That's fun. So that's a good way to test if they're paying attention reading the book.
I don't think anyone has.
They give it to every. They give it to
any
every
Inception patient who wants
every...
a copy of the book. Yeah, they have it in the waiting room. People can take a copy. Yeah, they ordered thousands and thousands of books. Yes.
Do you ever go to Inception clinics and do signings?
I haven't done that, actually. That's a good idea. I mean, I did a book signing.
That's next. Let's go, Faring. You got something else to sponsor. Let's do book signings at different clinics.
I did one at ASRM last year at the Inception booth, and we ran out of books within 10 minutes.
Nice.
Yeah, it was fun.
Was that the updated version of the book yet?
I think it was actually two of my other books. I think it was Be Happy with That Being Perfect and Self-Nurture. It was for people attending ASRM. It wasn't for patients.
All right, well, let's do it again. You have a talk coming up at ASRM. By the time this episode airs, that talk will have already happened.
I know.
So what did people hear about at ASRM?
So Liz Grell and I are doing it together. It's an inaugural symposium in honor of Dr. Schlaft, who died recently, and his family is sponsoring it. So Liz is going to talk. I mean, I'm the chair, so I'll sort of open the thing, but Liz will talk about sort of what we know in terms of research on burnout and burnout prevention. And then I'm doing real hands-on, like, let's do some relaxation techniques, talk about cognitive strategies. How can you better care for yourself? And then we'll do Q&A.
What will Dr. Grill talk about that I haven't asked you about yet with regard to what we know about physician burnout?
It's actually clinician burnout. It's not just for docs. I saw her talk. You'd think I'd have this at the tip of my tongue. I think she presents a lot more data than has been known on burnout in the REI field. What physicians are reporting, and there's research out of Europe, and then ASRM every few years surveys REI nurses. And she's going to talk about nursing turnover and how it's basically doubled in the last 5 or 10 years. I mean, nurses used to stay in the field for 4 years. Now it's 2. And it costs clinics a fortune to replace a nurse.
Wow. And over what period of time is that?
So it used to be nurses would stay in the field for 4 years, and now it's 2.
Yeah. Wow.
Yeah.
And do we know over how quickly of a span that changed? Like, was it 4 years average in 2020?
I actually
and now
don't
it's
know.
2?
It's ASRM data. It's not my data.
That's
but
such
the nurses,
a big deal.
They do the survey and they ask them. And, a nurse right now isn't just a nurse. She's a travel agent, and she's a counselor, and she's a pastoral person. And, then these nurses have to wear 10 different hats. And they also have to understand the technology because most networks now use portals. And so they have to understand how to work with the portals and how to use EMR. And nurses, honestly, are the ones that are sandwiched between these frantically anxious and depressed patients and the physicians. And patients aren't going to take their angst out on the nurses. They take on the physicians. They take it out on the nurses and the support staff.
They get ignored a lot too, don't they, the nurses?
Absolutely. Yeah, they do.
I know it because, or at least from where I stand, because I have built a living making a trade media company for the fertility space. My audience is the people that work for, operate clinics, the clinicians, the business people, the embryologists, and I have different companies that market on our media platform to those different constituents. And the reason why we don't make more content for and about nurses is because it's really hard for me to get companies that want to target them because they just don't feel like they make a lot of decisions for whatever it is they're selling. So if
Do you see
I'm,
my eyes rolling?
yeah, yeah, and I
They have
think
huge
thankfully,
influence.
yeah,
Nurses have
thankfully,
huge influence.
I 100%. And what I think they need a larger microphone too.
Absolutely.
And I've been working on different companies and I'm like, just give them the mic, give them our microphone and let them have a bit more of a collective voice and you'll see how influential they are. And I think that I've gotten a couple people to bite on that. I think one pharmacy in particular really understands the importance of nurses, but it's an area where I feel like this is something we should be talking way more of. I mean,
Huge.
that fact, I didn't know it in those terms. I could have intuited something like that, but just the fact that you can button it down to fertility nurses used to have an average tenure of 4 years. Now it's 2. It
Huge.
can't have again, right? Like you can't let that have again because then you're talking about an average tenure of 1 year per fertility nurse. Like you can't run a
Well,
clinic
it
like
takes
that.
a year to get a nurse up to speed. And the practice manager of a big practice told me a couple of years ago that it cost the practice $300,000 to replace a nurse. So it's very short-sighted not to support nurses. And in fact, you should do a whole show with Liz and I that's just for nurses.
Done.
Yeah.
Done.
Because,
We'll do one
you know,
that is
it's
just for
the,
nurses.
I worry about the whole staff. I worry a lot about the front desk staff because they're the ones that often take the most abuse. And, globally, the front desk staff have high turnover rates because they're abused by patients. I mean, again, 90% of patients are fine, but it's that
Yeah.
10%. And I'm just making that number up. And,
No,
they,
wait. I didn't want to interrupt your thought. I was thinking back to something you said earlier, where now the nurse she's not just a nurse anymore. She's this administrative assistant. She has to do it. That's unacceptable in my view. And we have to have a louder voice that nurses should not be doing all of this admin work, especially when the technology exists there. And I don't know if it's the frames out there who I think have a good reputation, Conceive, Levy Health, Engaged MD might be working on some more stuff. There's other folks that I'm forgetting that I'm going to feel bad about not including, but these types of solutions are out there, and it's not okay to just say, well, the nurses are just going to call people. One, because that really restricts your patient pipeline as well, but two, we're driving nurses out of the field by doing that.
and it's, so if you have a nurse who's burnt out, one of the symptoms of burnout is you lose compassion. You just, they become, automated and the patients notice and then the patients drop out or the patients post a bad review. And so there are 1,000 reasons why we need to take better care of our nurses, for the nurses' mental and physical health, number one. But clinics run on nurses. In
I don't
Boston,
want
we
to.
say people run on Duncan.
Yeah.
Infertility clinics run on nurses.
Who do you think of when you think of most of your healthcare experiences? You think of your interactions with the nurse. That's the person that that is representative of your experience in a fertility practice. And if they're not engaged, then good luck improving patient engagement.
Well, it's interesting because, 30 years ago, nurses got gifts every day from patients. Like, I remember you'd go into the Boston IVF lunchroom and there'd be baskets of muffins or bagels or cookies or fruit baskets, et cetera, that patients would show their appreciation to the nursing staff. And they don't anymore. And it's not funny. So a couple weeks ago, my father-in-law was dying. He was in an ICU and he actually died. But, the second day and I was his healthcare proxy. So I spent a lot of time there. And I noticed that the nurses had been given a box of chocolate. And I said, "Oh, do you guys like chocolate? I'd be very happy to bring in a box of chocolates for you." And you know what they all said to me? "Please just write a thank you note." No one writes us thank you notes, but when someone does send us a thank you note, we post it in our break room. And every time we've had a bad moment with a patient, we go into the break room and we read those notes. So my husband and I wrote long notes for the ICU staff and the ER staff. I still brought donuts every day, but they want to be appreciated. And, again, 30 years ago, 20 years ago, even 10 years ago, patients showed their appreciation. And, we have a new thing at Inception that every month the patient experience director assigns each executive all the employees who got a shout out on social media. And each of us is assigned however many employees at that clinic got a shout out on social media. And we have this, what's called a bonusly program where people get bonusly points and they can use the points to get, gift cards for pretty much anything. And so every month, every executive gets assigned. And so what we do is, I see what the shout out is and I send a message to that employee with bonusly points. And it's broadcast to the entire company. And that way we are acknowledging every employee who got a shout out from a patient. But it should be thousands of shout outs per month, and it's not. The patients are just not acknowledging when employees take really good care of them. They post negative reviews. They don't post, it happens once in a while, but it should be thousands, not dozens.
I would have thought that nurses were still getting a lot of thank you notes. I wonder how common that experience is. And I think it's a good poll question for us to put out there to fertility nurses. Do you get more or less thank you notes than you used to? And what you just said is it should be thousands. I think that in today's day and age, we're so used to expecting everything to be instant. We're expecting everything to be catered to us, that we've learned some bad habits as a consumer population, and that people need to be disabused of some of those bad habits. And that was one of the things that I would try to get practices to think about in their marketing, that they should talk a little bit about nursing burnout or compassion fatigue in their marketing.
They should talk a lot about
Well,
it.
so they should definitely talk a lot about it, but they should talk about it a little bit in their external marketing to patients, because I want patients knowing that my nurses aren't robots, that they're not these cold steel avatars that don't have emotions, that they are really trying their best, that they have so much on their plate. And if I'm coming in with that as my my preface, then I can start being more grateful for what they do, because what's the expression? Gratitude is expectation minus delivery, or minus
I have
actuality.
no idea.
So if my expectation is that everything should just be perfect, and how dare it not be, then I'm not going to be grateful. But if my expectation is, wow, these nurses really have a lot on their plate, then I might start to be grateful for what they're doing, and express that gratitude. You've got me fired up about nurses, and I am going to have you and Dr. Grill back on, and I'm going to think of some sort of goal. I think I can get, I don't want to speak for them, but I'm going to speak for them a little bit anyway, to sort of like, to put it into the atmosphere, like Mendel's Pharmacy. I think I can get them to help a little bit with this, because they really appreciate nurses. They're one of the people that actually stick up for them, care about them. I think I can get them to help out a little bit, but I want to 2026. I made a New Year's resolution a couple years ago that I was going to do a lot more content for embryologists, and then boom, it happened. And we
They're
got
stressed too, by the way.
more.
Let's not forget embryology. I just was part of a big study that was published last year. Embryologists are very stressed. And because, in most of what one does, a mistake can be remedied. An embryologist mistake can't be remedied in general. So everything they do is really high stakes.
Are they part of the people that you address?
Yes.
So when you talk about clinician
I
dropout,
always seek out embryologists. And in fact, several times now I've gone to New York and literally taken out all the NYU embryologists for a nice steak dinner, just to show how much we appreciate them and talk about stress management and everything else. Yeah, embryologists. I would say that when I go to clinics to do these stress lunches, and then I sort of sit in an office just to do one-on-ones with anybody, a lot of the people who come talk to me are embryologists.
Well, I am going to have you back, and we'll talk more about embryologists because they deserve their time. And I'm going to have you back to talk about nurses because I can't get enough of you, Allie. Thank you for coming back on the show.
Sounds great. Thanks for inviting me.
Go to data.insidereproductivehealth.com. That's where we're compiling so much data on new technology in IVF, products and services, market analyses, info and mergers and acquisitions, every data point that we can on the field writ large and the companies in the fertility field, we're compiling there. Go to data.insidereproductivehealth.com as we build that over time. And if your company isn't an IVF Heroes Universe sponsorship, your competitors are getting more visibility because we report on your category and we give that to your customers. We do that multiple times per year, and we do it around big events like ASRM and ESHRE. Go to data.insidereproductivehealth.com and submit your company today. Don't be left out.
Today's advertiser helped make the production and delivery of this episode possible for free to you. But the themes expressed by the guests do not necessarily reflect the views of Inside Reproductive Health, nor of the advertiser. The advertiser does not have editorial control over the content of this episode, and the guest's appearance is not an endorsement of the advertiser. Thank you for listening to Inside Reproductive Health.